Hello and welcome to this episode of the VJNeurology Podcast, where we will be showcasing some highlights from the Sleep 2026 conference, which took place in Baltimore, Maryland, from the 14th to the 17th of June. This podcast is part of the Sleep Disorders channel on VJNeurology, which is supported through educational grants from Takeda and Alchemies. These supporters have no influence over the production of the content. This podcast is intended for healthcare professionals only. We begin with some updates in the management of insomnia. First, Emerson Wickwire discusses the new American Academy of Sleep Medicine guideline on combination treatment for chronic insomnia disorder in adults. Michael Mack will then share key takeaways from the VA/DoD clinical practice guidelines for the management of chronic insomnia disorder and obstructive sleep apnea. Finally, Michael Grandner discusses the role of stimulus control and sleep restriction therapy in reprogramming the brain to treat insomnia.
Combination treatment for chronic insomnia disorder includes both behavioral treatments as well as medication treatments, oftentimes administered concurrently, although at times sequentially. The task force reviewed the literature and 15 studies were included in a meta-analysis, which resulted in a clinical practice guideline. There are two key recommendations. The first is that, generally speaking, it's a conditional recommendation that combination treatment should be used over medication treatment alone. And the second recommendation is that combination treatment should not be used over CBTI alone. Now, what the key to keep in mind is that there are very few adequately powered clinical trials to answer these questions. And so the task force identified far more future research questions than there were clinical recommendations. Some of those key research questions to be asked and answered in the future are adequately powered clinical trials, comparative effectiveness research to look at the long-term outcomes. So who are the patients, if any, who benefit from combination treatment relative to either insomnia alone, either insomnia medication alone or CBT alone, looking at issues like durability of effects, and of course, looking at cost benefit broadly defined.
The key takeaway for the recently released VA and DoD insomnia and sleep apnea guidelines, they remind us to use cognitive behavioral therapy for insomnia as a first-line treatment. Barring that, if you're not able to access CBTI, brief behavioral therapy, which is the distilled version of that kind of therapy, can also be used. The guidelines specifically state not to use sleep hygiene education by itself as a treatment for chronic insomnia disorder, meaning that these are people that meet the criteria for having problems falling asleep or staying asleep, waking up too early 3 times a week for 3 months straight, causing daytime distress. If you have that kind of insomnia, sleep hygiene by itself is not going to help. So outside of first-line treatments, which include the psychological therapies, the guidelines do suggest some pharmacotherapy. So there they discuss, consider trialing the 3 DORA medications, i.e. suvorexant, lemborexant, and daridorexant. And then for people with sleep maintenance issues, doxepin, which is a sedating antidepressant medication. And then there's the 3 Z drugs, ezopiclone, Zalopon, and Zolpidem. So those are the types of medications that you can choose to try if you have a patient that needs short-term treatments that are maybe unable to engage in the psychological treatments, or where they've tried the psychological treatments and didn't work out.
So treating insomnia, especially treating chronic insomnia, the methods that you want to use focus on the issue of conditioned arousal. What happens with chronic insomnia is that what starts as a sleep problem becomes predictable. Sleep starts becoming predictably stressful. And that predictable stress becomes a little bit of anticipation and worry about not sleeping. You get into bed worried a little bit that you might not be sleeping. But that increases the level of activation in your mind and your body, which makes it just a little bit harder to fall asleep or stay asleep when you wake up. And so then that actually strengthens the relationship between sleep and stress and pairs them together because they become a stronger pair, which then makes you anticipate and fear sleep a little bit, which then increases that activation, which makes it harder to sleep, which then increases the pairing, and it becomes this cycle that just feeds forward. And so whatever caused the initial insomnia isn't even really always in the picture anymore. It's this cycle of worrying about sleep, which increases activation, which makes sleep harder, which then makes you worry about sleep. And so the answer and the most effective way, and there's decades of data that show this, the most effective way to fix chronic insomnia is actually to reprogram the brain and help it relearn how to sleep. And stimulus control and sleep restriction therapy are two of the most effective ways to do it. Now, sleep restriction therapy is tricky because sometimes it can be rather extreme, and you really need someone who knows what they're doing to oversee it. It's not something I'd recommend people do on their own. And in terms of helping with it, if you have a therapist who is helping walking you through sleep restriction therapy and you're feeling worse at first, that might be part of the process, because part of what sleep restriction therapy does is it drives up your natural sleep drive enough to kind of overpower whatever those mental blocks are. But that's why you need a trained therapist to help make sure you're still staying safe and within the boundaries of what's working. And you don't get frustrated. Once you start it, you kind of have to power through, or else it's not going to be as helpful. But for that one, I think it's more about getting someone who knows what they're doing to help you. Stimulus control, that's another one where it's extremely effective. What stimulus control is, it's, in a nutshell, it's gaining control over what the bed is a stimulus for. Is it a stimulus for sleep, or is it a stimulus for wake and worrying? And for a lot of people, the bed becomes the place where you're not asleep. It becomes the place where sleep is not predictably going to happen. And you want bed to equal sleep. And if you can control the bed side of the equation, but not the sleep side of the equation, that's where you start. If you want bed to equal sleep, and right now bed does not equal sleep, you got to get yourself out of bed. Not bed needs to be not sleep. So what that means is if you're in bed and sleep isn't coming, don't be there. If you can't make yourself hungry, you can't speed up your own metabolism, you can't make yourself sleepy. If there's something outside of your control preventing you from sleeping, fighting it isn't going to make you fall asleep faster. The trick is, let your natural process start working the way it wants, and it will get better. But it takes time. People will say things like, well, I tried getting out of bed, but it didn't make me fall back asleep any faster. Well, it's not going to tonight. It's not, getting out of bed doesn't make you sleepy. What getting out of bed does is it slightly weakens the bed equals wake connection. And if you do that enough and reliably over time, and you only are in bed when you're sleeping, it strengthens that bed sleep connection. It's a slow process. It's a gradual process. And when people get frustrated, it's because they feel like it's not working fast enough. And again, this is why sometimes you need an experienced therapist or somebody who knows what they're doing to help coach you and guide you through the process to make sure you're on track, because sometimes it might feel like it's not working. But if you look at your data, you'll actually notice you're going in the right direction, just a little slower than you think, but slower and steady. And that's why when most people finish these sort of behavioral procedures for insomnia, this brain retraining and it's part of CBTI, cognitive behavior therapy for insomnia, when people go through it, often they never have to get treatment for insomnia again. Because not only that does it last because you've rewired the process, but you also know what to do when you have new problems arise.
Next, we move on to some updates in restless leg syndrome. It has recently been recognized that the first-line treatment option, traditionally dopamine agonists, should be reconsidered due to the risk of augmentation. Diego Garcia-Borreguero discusses alternative first-line treatment options and other updates in RLS, including novel treatment strategies and advances in understanding the pathophysiology. Arthur Walters then shares insights from his presentation given at the International Restless Leg Syndrome Study Group annual meeting on the genetic basis of RLS.
Yeah, over the last 2 years, a major change has occurred in the field of treatment of RLS. Namely, the American Academy of Sleep Medicine has finally recognized that the first-line option should be reconsidered. The first-line treatment option should be reconsidered. Until then, the official policy was that new patients or patients, previously untreated patients, should be treated first with dopamine agonists. There were a few years where they put at the same level dopamine agonists with gabapentinoid drugs. However, the problem of the dopamine agonists is that over time, they are going to lead to a to a complication called dopaminergic augmentation. That is an increase in symptom severity that is usually long-lasting, leads very frequently to treatment discontinuation, and worsens the quality of life of patients. That has been gradually recognized by the experts in the field. And finally, 2 years ago, the decision was taken that dopamine agonists should be, whenever possible, postponed. I wouldn't say avoided, if possible avoided, but in general postponed. The first line option should be a non-dopaminergic one. Okay, what do we have if we are not going to use the dopamine agonist? The alternative is going to be, in the United States, you have one non-dopaminergic drug that is approved, and this is gabapentin and acarbil. But in general, just to group the entire family of drugs, we call them gabapentinoids. These are drugs that that exert their effects by reducing glutamatergic function. Because the assumption is that in RLS, some neural circuits, particularly the corticostriatal pathways, which are glutamatergic, are hyperfunctioning. So the effect of gabapentinoids, whether pregabalin, gabapentin, or gabapentin and acarbil, is going to be to reduce that function, to diminish the hyperglutamatergic tone. These drugs have been shown in several clinical trials to be, over the short and over the long term, as effective as dopamine agonists are, with the advantage that they do not cause augmentation. However, what is their downside? Their downside is that the rate of side effects can be, I would say, slightly higher. And also there is another problem, that once a patient has started a long-term treatment with a dopaminergic agent, the longer the patient has been on that dopaminergic agent, the less the patient will respond to a gabapentinoid. That has been also been shown over the last years. So if you use them as a first-line treatment before anything else is being used, because that's the time point at which they're going to be most effective. However, there are some few problems that have been known over the last years. These drugs can have some short-term side effects, but over the long term, there are some reports, some prospective epidemiological reports that show that the rate of incidental dementia can be increased. The relative risk of incidental dementia following a treatment with a gabapentinoid is 1.4, approximately 1.4. That means compared to the same population, but those that are not being treated with gabapentinoids, there is a 40% increase in the rate of incidental dementia. What does it mean? These patients meet criteria for dementia, but we do not know whether this dementia is reversible or not. In most cases, it is. However, there is some speculation on whether there is a portion of the cases where what a gabapentinoid might be doing is accelerate other concurrent problems leading to dementia. For example, the rate of phosphorylation. This all comes from animal studies. The rate of phosphorylation of tau protein is increased. Also, the expression of hippocampal SIRT1 protein, which is one of the factors involved in the pathogenesis of dementia, is also increased. These drugs might also interfere with synaptogenesis, with the formation of new synapses. So there are reasons to be careful. So what do we recommend? We recommend to do a baseline evaluation of cognitive function, the risk of dementia is highest in those patients where the renal function is working worse. So periodically, systematically check serum creatinine and also check GFR, the renal function, basically. And this is most likely going to be impaired in the elderly patients. So be careful with the total dose. Well, there are updates in two very different directions. One of them is in our knowledge of the pathophysiology of RLS. We are getting to know more about the mechanisms leading to RLS, about the dysfunction of the basal ganglia, the functional dysfunction. I don't know whether you can say it's not a nice word, but I mean the dysfunction really in the sense that there is not a structural change in the basal ganglia, unlike Parkinson's disease. In RLS, there is no anatomic abnormality in the basal ganglia, but it's just a dysfunction. That dysfunction is being caused ultimately by decreased brain iron levels. And that will lead ultimately to a reduction of adenosine levels in the striatum. And that will, adenosine is a substance that normally reduces glutamatergic hyperfunction. Once adenosine is decreased, extracellular adenosine is decreased, and this is part of the result of the decreased iron levels in the brain, that will give way to corticostriatal pathways, which are glutamatergic, being unleashed, being hyperfunctioning, and that will lead to the symptoms. So knowledge in that direction is increasing year by year. We are starting also to know about the genetics, about this kind of how the genes interplay with that. And we believe that in a few years from now, this will also be the basis for new therapeutic options in RLS treatment. For now, what we know that was published a few years ago is that a substance that increases adenosine, extracellular adenosine like dipyridamole, is an agent. It's a substance that improves RLS symptoms. This is a proof of concept study that is already out there in the literature. And what we are considering is new agents that do something similar, but in a more perfectioned way than dipyridamole. The other treatment innovation comes from neural stimulation. Devices like the TOMAC, which is peroneal nerve stimulation, provide a way of treating very severe patients, and in that way, making them putting them in a position in which they can afford reducing the dose of dopaminergic treatment. Well, not only of dopaminergics, also of opioids, if they're taking any opioids. So these very severe patients, while using peroneal nerve stimulation, are going to be able to reduce the doses of pharmacological treatment in general.
Just to give a background on the genetics of RLS, about 1/3 of it is thought to be familial. And there have been several studies that have looked for actual causal genes in RLS. And they've not been able, through linkage, that's the technique that's used, to find an actual gene associated with RLS, but they found several linked chromosomes. But the other way that genetics has been approached in RLS is to do GWAS studies, genome-wide association studies. And these are studies where you look for a gene that occurs more frequently or single nucleotide polymorphism in RLS. It doesn't imply causality, but it implies some kind of connection. So what we did was we took it a step further. What we did was to take a look at, because we were looking our basic project was to look for comorbidities in RLS. And it's been known that there are many comorbidities that are different diseases that occur more commonly with RLS, such as hypertension and heart disease and stroke and immunological diseases such as multiple sclerosis and rheumatoid arthritis, hypothyroidism. And so what we did was there's a worldwide catalog of all the GWAS studies that were done. And what we did was to take a look at the SNPs, single nucleotide polymorphins that are more common in RLS, and find out if in that same catalog, those same SNPs were associated with other diseases, such as the ones I mentioned before. And it turned out that they were. So that the first study that we did would imply that the overlap of those comorbidities with RLS may have a genetic basis because they actually have the same change in the DNA. And then the second study we did was a FEWAS study. Now, a GWAS study is where you take the trait, for example, the restless leg syndrome, and you try to find out the genes or polymorphisms that we talked about. And as I mentioned, there are about 365 of them. So a FEWAS study is just the opposite. What you do is you take the genes that you've discovered and you throw them against a huge population of patients. Random population of patients. So at Vanderbilt, we had 72,000 some patients that were already genotyped. And what we did was compare the known SNPs from the GWAS catalog to the SNPs that the patients actually had. And the outcome, the endpoint, was to find out what diseases they had. And it turns out, yes, they had more hypertension. I think actually clinically. So you go from the gene to the trait, as opposed to GWAS, you go from the trait to the gene. And they had more hypertension and multiple sclerosis and immunological disorders. And we actually found perhaps a new locus for multiple sclerosis and some of these immunological disorders that actually had not been found in the GWAS catalog, but the patients did have more of these immunological disorders. A lot more has to be done to prove that it's an actual locus. But again, the research makes the same point that maybe a part of the reason that these comorbid disorders exist or coexist with RLS may have a genetic basis.
We will now move on to some updates in narcolepsy. At Sleep 2026, updated data on orexin agonists in the treatment of narcolepsy were presented. Nancy Foldvary-Schaefer and Lucie Barateau will share insights from the pivotal trials. And then Nancy Foldvary-Schaefer will discuss the DUET study, which is exploring individualized dosing of low-sodium oxybate for narcolepsy and idiopathic hypersomnia.
Yes, so the primary data shared at Sleep 2026 was related to oveporexton, which has completed phase 3 trials and has ongoing new trials, as well as alixorexton, which has completed phase 2 trials in narcolepsy type 1 and narcolepsy type 2. In oveporexton, we have narcolepsy type 1 trials. And what we see in both of these agents is remarkable improvements in objective daytime sleepiness as measured by the maintenance of wakefulness test. Quite significant improvements, such that a significant number of patients reach sort of a normal level on the MWT, as well as remarkable improvements on the Epworth Sleepiness Scale, which is our standard subjective measure of daytime sleepiness. Again, of a magnitude that surpasses many other agents already on the market. But in addition to that, improvements in weekly cataplexy rate for patients with narcolepsy 1 that are also quite impressive, and then improvements in clinician-rated and patient-reported quality of life and functional impairments. These drugs as a class have as a common initial adverse events urinary frequency and urinary urgency. This tends to be most bothersome to patients when they're initially getting treated with these agents, and then this tends to dissipate with time. I just saw a patient who's in one of our open label studies who no longer is bothered at all by these urinary symptoms. In addition, some patients may experience insomnia because these are alerting agents that have longer half-lives than some of the agents that we use routinely. But also, I think in the patients that I've managed through these clinical trials, this also is something that resolves with time. But these are thought to be adverse events or side effects that are related to the medication class rather than a specific orexin agonist, and perhaps due to some activation of the micturition pathway, which is a part of the brain that controls urinary symptoms.
So oveporexton is a highly potent oral receptor 2 selective agonist, and it demonstrated significant improvements in narcolepsy symptoms in 2 phase 3 trials. So these were placebo-controlled clinical trials called the First Light and the Radiant Light studies. And so we had information about objective wakefulness on MWT and sleepiness on the Epworth sleepiness scale, and also the cataplexy frequency. So these were the endpoints of the study. And compound was safe and well tolerated, and it showed a lot of improvements in all the endpoints studied, with huge reduction in cataplexy frequency and a major improvement in wakefulness and subjective sleepiness in narcolepsy type 1 patients. Indeed, it was also presented at Sleep Congress, but it's not yet published. So what I will say is very hypothetical, but we think that given the pathophysiology of narcolepsy type 2, probably the effectiveness will be different, and maybe we'll need different doses, but this needs to be proven. Narcolepsy type 2 is disease where we have no biomarker, but we know that orexin is supposed to be normal. So if we perform a lumbar puncture, orexin is normal in narcolepsy type 2, whereas in narcolepsy type 1, patients are orexin deficient. So probably the orexin receptor 2 agonist will have an effect on wakefulness, as they do in healthy controls, and it was in the phase 1 and previous studies, but it will be slightly different because it will not act specifically on the pathophysiology of the disease. So this is really new, and we have to wait for the published results, but it seems that it works. It's a wake-promoting agent, but it works probably differently with different size effects, etc. And now that we have these new drugs that are really a revolution in the sleep field, we do want to know the orexin status of the patients, because the strategy will be different if we know the patient is orexin deficient. And for example, we have some narcolepsy type 1 patients with no cataplexy. It's 20% of cases. So if you don't do the lumbar puncture, you don't know if they are orexin deficient or not, then probably it will guide the treatment choice. So we will give, for sure, we will try to give, when it will be available, orexin receptor 2 agonist to patient orexin deficient. For the others, maybe the strategy will be different. Maybe we will try other wake-promoting agents before this one. I don't know yet. It's a new field. But yes, orexin deficiency is more than ever a biomarker of major importance in hypersomnolence disorders.
Yes, so lower sodium oxybate, it's FDA approved for the treatment of narcolepsy and idiopathic hypersomnia at doses up to 9 grams per night. And new data from the Jazz Duet study, which is a phase 4 study of lower sodium oxybate, demonstrated how patients and clinicians together can make decisions to titrate up to 12 grams per night, either in even doses or asymmetric doses for narcolepsy and for idiopathic hypersomnia. And so what we showed is that there are many combinations that healthcare providers chose by listening to the patient's symptoms or concerns. So in other words, patients who felt that they would benefit by going higher, and we do have data supporting that higher dosing beyond 9 grams improves outcomes in patients with both of these types of conditions. But perhaps patients who have to wake up early and need to be very alert in the morning might favor taking a higher dose earlier for their first dose rather than their second dose, or patients who may have difficulty falling asleep at night might favor being on a higher dose in the first dose rather than the second dose. So these abstracts provided demonstration that there can be a lot of flexibility in deciding which patients benefit from more of an asymmetric dosing versus a symmetric dosing. And with the patient's, input, we can achieve better outcomes that are very satisfying to patients.
Atul Malhotra will kick us off next with some updates in obstructive sleep apnea. He will first reflect on the SURMOUNT OSA trial and the integration of GLP-1 agonists into OSA treatment, and then he will share ongoing research and emerging treatment approaches. Karin Johnson will then discuss AASM guidelines for the management of sleep apnea in hospitalized patients.
Sure. The SURMOUNT OSA study was published in the New England Journal of Medicine in 2024. And in fact, it was 2 studies. So study 1 were patients who couldn't or wouldn't use CPAP were randomized to tirzepatide or placebo. And study 2, patients who were using CPAP were randomized to tirzepatide or placebo. The primary outcome was the apnea-hypopnea index, which did improve both clinically and statistically significantly, about 25 or 30 events per hour improvement in the 2 studies. In addition, there were secondary outcomes that were both pre-specified and controlled for multiple comparisons. That included systolic blood pressure, which markedly improved, high sensitivity C-reactive protein, which we know is a strong cardiovascular risk marker, improved, the sleep apnea-specific hypoxic burden, which is also a cardiovascular risk factor that improved. The patient-reported outcomes were also improved markedly. You have to be careful of patient-reported outcomes in studies that are hard to blind, but concomitant improvements in objective and subjective outcomes were quite compelling. And then body weight improved considerably, about 18 to 20%. So to put that in context, if you start at 200 pounds, 20% would be 40 pounds. That would take you from 200 pounds to 160 pounds. So quite a marked improvement and a game changer for those patients. And on the basis of that study, FDA approved tirzepatide for the treatment of moderate to severe sleep apnea in people with obesity in December of 2024. Yeah, so these GLP-1 receptor agonists are really taking things by storm. So I was told about 1 in 4 Americans has tried a GLP-1 receptor agonist, so it's certainly out there whether you realize it or not. Many of the patients I see now are already getting GLP-1 receptor agonists from their primary care, from their referring physician. And many patients now come to the sleep clinic seeking a sleep apnea diagnosis to help get insurance coverage for tirzepatide since the FDA approval. And so it has become quite an important advance, and many patients are looking for weight loss as a potential treatment. It is important to emphasize, though, that the SURMOUNT OSA study didn't compare tirzepatide to CPAP. And so the first-line treatment remains CPAP. That hasn't changed. People are talking about doing comparative effectiveness studies where you compare CPAP to tirzepatide. But for now, first-line treatment remains CPAP. Adjunctive therapy includes tirzepatide to help manage cardiovascular risk markers. If people can't tolerate CPAP, then tirzepatide is a reasonable alternative as well in people with moderate to severe sleep apnea and obesity. Of ongoing trials, both in pharmacology and in devices for treatment of sleep apnea. It's an exciting time. There are many other weight loss drugs that are being looked at. So retatrutide is a GLP-1 with GIP with glucagon agonist. The TRIUMPH-1 and TRIUMPH-2 results were announced at the American Diabetes Association last week. There are some sleep apnea studies in the TRIUMPH studies as well, but those results are not yet publicly available. In addition, there's an oral GLP-1 called orforglipron, and there's a study called ATTAIN-OSA, which should read out in the next few months as well. So we don't know the results of that as yet, but oral options to facilitate weight loss and treatment of sleep apnea are currently being studied. Other treatment approaches pharmacologically for sleep apnea are ongoing as well. Jan Hedner from Sweden has a molecule called sulthium, which is a carbonic anhydrase inhibitor. He had a paper in The Lancet in 2025 that looked promising, and I believe there are further studies looking into that. In addition, there's a drug combination of 8109. That's atomoxetine with oxybutynin, or it's an enantiomer. And the phase 3 study results of that were announced at the American College of Chest Physicians in 2025. And during the recent American Thoracic Society meeting, one of the phase 3 studies by Pat Stroller was announced as well. What they're seeing there is about a 3.3 event per hour improvement in the apnea-hypopnea index. So placebo got slightly worse by 0.7, and so the placebo-adjusted improvement and the apnea hypopnea index is about 4 events per hour. They did not see symptomatic improvements compared to placebo, but there was some regression in the mean where both the placebo and the drug were improving. There was a pre-specified subgroup of the most symptomatic patients, and those did seem to improve with the drug. There's some improvements in snoring and hypoxic burden in the secondary outcomes as well. So that's being sent to the FDA. The AHI improvements are somewhat modest, but we'll see if the FDA approves it and what comes of that. There are other approaches to sleep apnea treatment, which are ongoing as well, including various kinds of hypoglossal nerve stimulation are being looked at and other device-type strategies.
So the ASM put out a new guideline for the treatment of obstructive sleep apnea in hospitalized patients. They started with a good practice recommendation was that if a patient is already using a treatment for sleep apnea at home, to continue it while in the hospital. And that's irregardless of whether it's CPAP or a mandibular advancement device or hypoglossal nerve stimulator. There may be some patients where it's not appropriate to continue, treatment. If they're in there with respiratory failure, they might need a different level of treatment. If they've had facial trauma, they might not be able to continue a CPAP. But all other things considered, recognizing that they do have sleep apnea, it's very important. A lot of patients aren't asked about it, whether that is a treatment they have at home. So making sure it's sort of part of, the med rec to also do that sleep apnea treatment rec is important. And use of EHR might be able to help screen better for recognizing those people. And then the other recommendations, they're all conditional low evidence recommendations. We still need a lot more research in this area, but we did find positive studies to really support the use of sleep medicine consultations in the hospital, led by a sleep medicine physician to really help coordinate care. And this might be as simple as connecting people into outpatient care so that they can start on treatment timely after the hospital. But if able, based on the resources, to get people being treated and diagnosed. So one recommendation is for screening of high-risk patients. You may think especially about stroke patients, heart failure patients. That's the two areas that had the most data that is out there, that if we can do either screening tools or more objective tools like high-resolution pulse ox, and you can then, if you recognize that they potentially have sleep apnea, you can either go on to further diagnostics, potentially in the hospital, or again, connecting them outpatient to rapid diagnostics, or you might go straight to empiric treatment in the hospital. So there's actually data that suggests lower rapid response rates in people that are treated with CPAP in the hospital versus not. So that was some of the recommendations of if you either have newly diagnosed or diagnosed but untreated sleep apnea, to think about getting them on treatment during their hospitalization. And then again, there is potential data to do actual diagnostic testing if possible. Unfortunately, that's often not paid for at this point. So that often limits the number of hospitals that are doing it, but thinking about whether using portable, home sleep testing devices can be used in the hospital. And there's some data that supports even in heart failure patients who we don't necessarily go, for home testing, that might be useful. There's been a lot of data in the stroke population as well. And so really important to think about whether you can do treatment diagnostics if you don't have the resources to do it, to use that consult and use those resources to get people sort of connected for that treatment, not only for secondary prevention, but also, especially in patients like stroke, to help with recovery outcomes.
Finally, we hear from Umakanth Katwa on the IPSA Transition Task Force recommendations for transitioning pediatric to adult sleep care.
I'm the chair of the task force. We are in the process of developing these guidelines. There is not much literature in the pediatric sleep medicine regarding transition, but I think that is getting a little bit of more attention these days. So in this regard, in Sleep 2026, there is a lot of focus on transition medicine, particularly for all the chronic disorders of sleep, including obstructive sleep apnea. So as far as the transition is concerned, it is not one size fits all. You need to have a 3-tiered system where the most simple patient can be transitioned between pediatric specialist to adult specialist. Then comes the children with underlying complex medical conditions such as Down syndrome, other genetic disorders, which needs specialists who understand the diseases in adult specialty. And then comes the 3rd tier, which are children with extremely complex sleep disorders such as congenital hyperventilation syndrome, children with severe comorbidities, including Down syndrome, autism, or tracheostomy and ventilators. Those patients needs a multidisciplinary transition, which includes a respiratory therapist, sleep specialist, pulmonologist, neurologist, social worker, and so on and so forth. So in this regard, the first is to identify who are your patients, what age you want to transition, how stable they are, and who is the accepting physician, where they're going to go. Is the patient prepared to the transition? Does he understand the disease burden and what is the condition he's being treated on, the teenager, and then the parents. And then depending on that, you can start assessing, which typically should start pretty early in their teenage years, between 12 to 14 years of age, and keep on assessing until they are ready, between 18 to 21 years of age. And then for the complex patients, it could be 18 to 25 years of age. And extremely complex, depending on the availability of the resources, can transition between, again, 20 to 25, or sometimes in some institute, they may see up to 30 years. So it's basically developing a team who really understands the problems of teenagers or childhood diseases in adult medicine.
Thank you for listening to this episode of the VJNeurology Podcast. To see our full coverage of Sleep 2026, head over to VJNeurology.com. Be sure to follow us on X at VJNeurology and subscribe to our podcast on Spotify, Apple, or Podbean. Until next time.